Okay, well, welcome everyone to today's Pediatric Project Echo session on constipation. Dr. Malkani is a professor of pediatrics and department head of pediatric gastroenterology here at ETSU and chair for the Department of Pediatrics at Niswangers. She received her medical degree and completed rotating internships at Calcutta National Medical College at the University of Calcutta, completed her pediatric residency at All Children's Hospital at the University of South Florida, as well as a pediatric GI fellowship at Stanford University. She'll be speaking today on constipation, so please join me now in welcoming Dr. Malkani.
Good afternoon. Thank you for that introduction, and I'm going to go ahead and get started. Today's topic is constipation in kids. I have no disclosures, no potential conflicts of interest to make. Objectives for today's study, I'm going to review the normal stooling patterns and the pathophysiology of defecation. I'm going to review the differential diagnosis of constipation, the evaluation of a patient that comes with constipation, and I'm going to touch on the management of functional constipation and talk about some other etiologies of constipation in a little bit of detail. So let's start with a kid that comes to your office for constipation. It's a 4-year-old. He has intermittent constipation since he was 2 years old. Mother tried giving him prune juice and Karo syrup with not much help. Since he finished toilet training, his constipation has worsened. He stools once every 3 days. It's painful. And now he refuses to sit on the potty. He, however, pees with no problems. Otherwise, he's in good health. He's gaining and growing well. He drinks 3 to 4 cups of milk a day, likes to eat a lot of junk food and maybe some vegetables. On physical exam, he had palpable stool in the abdomen. He had a normal anal wink, no sacral dimple, normal rectal tone on digital exam, and he also had a large hard stool felt in the vault. So, what is your differential diagnosis? Anybody? No? Okay. It's probably functional constipation. Do we need to do any testing? We'll talk about this, and then we're going to talk about treatment, and I'll wrap up when I'm done reviewing functional constipation. We'll come back to this little kiddo, okay? So just some background. Constipation is common and curable. About 16 to 37% of toddlers are constipated, and most kids are curable. Depending what studies you read, 50 to 90% are curable, okay? And eating and pooping are things that all parents watch for in their kids. So everybody poops, okay? And we're always focused on pooping over here. So what is the epidemiology? About 3 million Americans a year receive medications for constipation from their physicians. And this is old data. Unfortunately, there's no recent data, and that's based on the US population estimate of 314 million. In pediatrics, and this too is an older study, it's about 15 to 18 years old. About 3% of visits to the general pediatrician are for constipation, but 10 to 25% of visits to pediatric GI are for constipation. So you can see constipation is almost the bread and butter for pediatric gastroenterology. Somehow that number seems to be increasing over the years. So what are the normal stooling patterns? We all know that breastfed infants stool more than formula-fed infants, but by 16 weeks, the number of poops that these babies have are equal, about 2 a day. A toddler has a bowel movement between 1 to 3 times a day, and in an older child and an adult, 95% will have a bowel movement anywhere from 3 times a day to 3 times a week. This is an old slide, almost, oh God, 20 years, maybe more than that old, that looked at the number of bowel movements that kids have per week and per day. And you can see in the first 3 months of life, breastfed infants have an average of 3 a day, where formula-fed have an average of 2 a day. And that number goes down as they get older to an average of about 1 a day. So What's the definition of constipation? In adults, there's a Rome criteria, which we also have in kids too, but in adults, it's defined as less than 2 bowel movements a week for more than 6 weeks. In children, we do have Rome criteria. I'm going to show you the slide, but it's easy to remember that if there's any difficulty in the passage of stool, or if there are symptoms associated with incomplete evacuation of stool, meaning there's stool retention enough to cause symptoms, that is equal to constipation. The North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition came out with their constipation guidelines, I think it was 7 years ago. And in those guidelines, the definition is described as a delay or the difficulty in defecation sufficient to cause distress to the patient. So the one thing you need to remember after today's talk is that you can have a bowel movement every day, but if you're not evacuating your colon completely or there's enough retention to cause symptoms, that is equal to constipation. So just remember this slide, that you poop every day and you can still be constipated. So this is the definition of constipation in a child greater than 4 years of age. This is the Rome criteria. You have to have any of the two. So less than 2 poops in the potty per week, at least one episode of incontinence a week, history of retentive posturing, history of painful or hard bowel movements, or on exam, you have a large fecal mass in the rectum, or there's a history of large diameter stools that may obstruct the toilet. So how do we maintain fecal continence? So this is a slide looking at the anatomy of the anorectal area. So the sigmoid colon is up at the top, and then the stool comes down to the rectum. And the rectum, once it starts filling with stool, when you reach a critical volume, there is relaxation of the internal sphincter involuntarily. So normally the rectum and the anal canal are at a right angle. And how is that held in a state of a right angle? It's by the puborectalis muscle that slings across from the symphysis pubis. So that's what keeps this anorectal angle at 90 degrees. In the anal canal, we have the internal anal sphincter and the external anal sphincter. The internal anal sphincter is in a state of tonic contraction, and it's involuntary, and it acts as a passive barrier to leakage of stool. The external anal sphincter, on the other hand, is a voluntary muscle, but it has phasic contractions that keeps this anal canal closed. So this is the anatomy. So there's a right angle, and there's a puborectalis muscle, and the internal and external anal sphincters that helps us be continent. So what happens when it's time to poop? So when it's time to have a bowel movement, the stool comes down into the anorectum. There's temporary relaxation of the internal anal sphincter. And then you have to decide. You allow that poop to escape, or you're going to hold it in. So if it's time to have a bowel movement and you've reached that critical threshold for sensation in the rectum, the puborectalis muscle relaxes so that 90-degree angle becomes a 180-degree angle. It's straight the canal. And then the external anal sphincter is a voluntary muscle that relaxes. And because this internal anal sphincter is also relaxing, because the volume in the rectum has caused the internal anal sphincter to relax. So your anal canal is open, it's relaxed, your 90-degree angle is now a 180-degree angle, and you have a bowel movement, okay? So that's the defecation dynamics. So what really happens that causes constipation? Either there's a decrease in the propulsive force of the colon, bringing the stool down to the rectum and anal canal, or there's impaired rectal sensation from dilation of the rectum, or there could be a functional outlet obstruction causing a barrier to this passage of stool, or there could be behavioral withholding, meaning that external anal sphincter, instead of relaxing at the time of defecation, starts contracting, and the child is actually voluntarily withholding. So if this voluntary withholding continues or the rectum starts getting distended and the critical threshold of volume of stool needed to cause the internal anal sphincter to relax gets higher and higher, there'll be a large collection of stool in the rectum, and then the liquid stool just starts seeping out and you start getting encopresis. Okay, so that's constipation-induced encopresis. So when we start seeing kids in the office with constipation, more than 95% of kids that come with constipation is usually functional. And you only need a history and a good exam to make that diagnosis. However, there are organic causes of constipation and we need to be aware of the red flags in either the history or the physical exam that point to a non-functional etiology. Because what the mind does not know, the eyes will not see, okay? So we have to be aware of what things that could be causing constipation that are not functional. So if we look at the differential diagnosis of constipation, it's a page long. So I summarized this. There's a non-organic and organic causes. So non-organic could be developmental. There's just cognitive delays. It could be situational, where there's difficulty in toilet training or the child develops a toilet phobia. They could avoid going to the bathroom when they start school, or there could be some sexual abuse that causes them to start withholding. They could have colonic inertia or genetic predisposition, or there could be reduced stool volume and dryness in the stool caused by low fiber in the diet, not enough fluid in the diet, or underfeeding or malnutrition causing a reduced stool volume. So looking at the organic causes of constipation, it's a page long. There could be some metabolic systemic disease, hypothyroidism, hypercalcemia, diabetes mellitus, diabetes insipidus, renal tubular acidosis, all causing dehydration, cystic fibrosis, celiac disease, lead poisoning, and the list goes on and on and on. There could be outlet resistance like anal stenosis, an anteriorly displaced anus, or Hirschsprung disease. I'll talk a little bit about them. You could have a stricture either from neck in the past or from inflammatory bowel disease causing a mechanical obstruction. You could have dysmotility from hypermobility syndromes or intestinal pseudoobstruction. There could be inflammation causing constipation, either allergic proctitis, even in an infant, or inflammatory bowel disease can sometimes masquerade as functional constipation. Many moons ago, I had a patient with what we thought had functional constipation. And then somebody realized a year later that this child isn't growing and did a stool fecal calprotectin. It was elevated and he ended up having Crohn's disease with a stricture in the colon. So inflammation can cause it. Drugs, either over-the-counter or prescription drugs, anticholinergics, diuretics, or antacids that cause constipation can be a cause of constipation. So we always have to ask about this. And if there's any altered sensory neural reflexes, either spinal cord lesions or a neuropathy can cause constipation. So we have to know what are the organic causes of constipation and be on the lookout for them, even though the most common causes for constipation are functional constipation, okay? What the mind does not know, the eyes will not see, okay? So let's talk a little bit about functional constipation. So what could be the initiating factor for constipation? There is this vicious circle concept that the child could have either a painful rectal condition or overzealous attempts at toilet training or difficult access to toilet facilities, like when a child starts school, and that causes the child to start withholding. So as a child starts withholding, the stool gets harder, drier, more painful to pass, and then the child is withholding more, and then there may be some seepage, a liquid stool around it, and they have constipation with encopresis. Not always that you will have this happen, but quite often you will. So functional constipation is typically idiopathic. It seems to be more common in males, 3 to 1. It usually peaks around 2 to 4 years when the child is starting to be toilet trained. And it's been found that an obese male with behavioral issues is the one that's going to not respond as well to the treatment for functional constipation. So evaluation of a patient with constipation. get a good, do a good history. A physical exam is more than enough to diagnose a kid with functional constipation. And sometimes you have to resort to some diagnostic test that I'm gonna talk about. Okay, so history taking. We need to get a good history about their current stooling pattern. How often do they poop? What is the size of the stool? Has it ever clogged the toilet? Do they have to break it with a stick? I'll ask all these questions in clinic. What's the consistency of the stool? And if there's any bleeding, if there's bleeding around the stool or is it mixed in with the stool? If there's any associated symptoms, do they have any bellyache? Is there any rectal pain? Do they have abdominal distension? Do they have to strain a lot? What is their appetite like? And do they have any withholding symptoms? So do they have any duty dancing, trying to withhold the stool? And then a lot of kids will also have urinary symptoms of either bedwetting is the most common thing. About 25% of kids will have bedwetting because there's a huge fecaloma pressing on that bladder. So this is a Bristol stool chart. A picture is worth 1,000 words. So we have this hanging in our office and clinic, and we will ask, what is your stool type? Is it 1, 2, 3, 4, 5, 6, or 7? Okay. So typically we want the kids to have either a Bristol 4, especially when they're constipated. The goal is to have a 4 every day. So I'll ask, does it look like rabbit pellets? Is it a bunch of grapes, a corn on the cob? Does it look like a hot dog and a chicken nuggets? Does it look like oatmeal or gravy? Okay. So when we're getting a history, we need to ask about if they've had any past surgeries, if they've had any anorectal surgeries, if they have any spinal cord lesions, if they were preemie and they had a history of neck, you need to start thinking, could they have a stricture? Any family history or any history of themselves of having inflammatory bowel disease. It's always important to ask the timing of the first meconium. If it's delayed, then we start thinking about Hirschsprung's disease. And then developmental history is important to make sure that they have their cognitive development is okay, and ask when they attained toilet training for both bladder and bowel. Drug history, if they've been taking any antacids, diuretics, or anticholinergic. Also have to ask about non-prescription medicines, not only prescription meds that could be constipating. In their diet, ask about fluid intake, fiber intake. Over the years, I've been finding that the fiber intake seems to be going down and down and down. Family history, if there's any family history of thyroid disease, cystic fibrosis, or celiac disease. Social history, if they have, if they're physically active or not. Kids these days seem to be watching more and more video games, playing more video games, and sitting more than walking. And if there's any defining events, if there was any change in their social situation, if they started a different school, if there was a birth of a sibling, if there's any marital issues, if they moved houses, anything that would make them start withholding. And then we always have to keep abuse in our differential diagnosis all the time about what caused the constipation. So on physical exam, look at their growth parameters. Most kids with functional constipation grow well. When you start seeing growth failure, you need to start thinking of some of the organic causes of constipation. Don't forget to examine their thyroid, make sure they don't have hypothyroidism. Do a good belly exam, make sure you don't feel any masses, no scars. I've been looking at the Beighton score to see if they have any connective tissue disorders. And then don't forget to do a perianal inspection to look at their anus, look at the tone of the gluteal muscles, and see if there's any telltale signs of any painful perianal lesion, like a fissure or a tag, the fissure that could have caused the constipation to continue to be an issue. And if you see tags, obviously start thinking of inflammatory bowel disease. Digital exam, it's important to feel the tone of the anal canal, looking for Hirschsprung's disease, and then look at the amount of stool and the consistency of stool in the rectal vault. We'll often do an anal wink to make sure the S1 reflex is intact and a chromastric reflex, making sure that there's no spinal cord lesion. Don't forget to look at the lumbosacral area to make sure that there's no hemangioma or lipoma. That is a telltale sign that there's something lying beneath there. And then always look to make sure that there's no presacral dimple or gluteal cleft deviation that tells you that there's some underlying neuromuscular issues. So what are the red flags that point away from functional constipation? If they have early onset of constipation, if they had delayed passage of meconium more than 48 hours, start thinking Hirschsprung's. If there's a family history of Hirschsprung's, most of the constipated, functional constipated kids will have big, huge poops that will clog the toilet. If they have ribbon-like stools, need to start thinking this could be Hirschsprung's disease. If there's blood mixed in with the stool rather than around the stool, you need to start thinking that there's something going on within the colon. With a fissure, it's usually just bright red blood around the stool. And don't forget to look at their growth, because if they have any issues with their weight gain or their linear growth, you need to start thinking of some non-functional causes of constipation, like celiac disease or thyroid disease, or even inflammatory bowel disease that can be masquerading as constipation. If they have low-grade fever, start thinking about inflammation. If it's bilious vomiting, need to start thinking obstruction. Don't forget to examine their thyroid. If there's severe abdominal distension, need to start thinking a more obstructive cause. If there's a perianal fistula, IBD, an abnormal position at the anus can also cause constipation due to an anteriorly displaced anus, where the stool has to make this turnaround to get out. The anal canal does not become 180 degrees with the relaxation of the puborectalis muscle, and that poop has to make this turn with an anteriorly displaced anus. So on physical exam too, the inner absent anal reflex, decreased lower extremity strength or tone, make you start thinking about some spinal cord lesions. If they have a tuft of hair on their spine, you start thinking about spina bifida. A sacral dimple could signify a tethered cord. If they have extreme fear during anal inspection, we need to start thinking, could there be some abuse? And then if there's any anal scars, you need to start thinking about if they have any surgical prior surgery, or once again, start thinking about abuse. So medical workup for constipation, functional constipation, usually a history and physical exam is enough to make the diagnosis. But by the time they start coming to see a specialist, they've already tried dietary interventions and it's not working. We'll often screen for thyroid disease, celiac disease, may get a lead level, and then a CBC looking for iron deficiency or calcium on this. It's usually on the panel anyway, to look for parathyroid hormone issues. Sometimes we'll resort to imaging and manometry, but for most functional constipation kids, just the history and physical exam is enough to make your diagnosis. So I'm going to touch a little bit about these tests. A KUB, we'll sometimes have to do a KUB in a kid who we think has functional constipation just to establish whether there's a fecal impaction in a child refusing a rectal exam, or an obese child where you can't really feel the lumps of stool on exam. So you may have to get a KUB. We'll sometimes resort to doing an unprepped barium enema to look for a stricture or a transition zone looking for Hirschsprung's disease. An MRI of the lumbosacral spine may be necessary to evaluate for a tethered cord. If you find some telltale signs on exam that make you think there's a tethered cord, you see a tuft of hair on the lower back. And rarely we'll have to do a Sitzmarker study where you swallow a capsule that has 24 rings in it, and you look to see what their transit time is. By the time you're getting to a Sitzmarker study, they've already come to GI clinic, and we're trying to establish what their, whether they have colonic inertia or they have rectal outlet dysfunction. So normally 80% of the little markers will have passed through when you do an x-ray at 5 days. If it's scattered throughout the colon and they're retained, it makes you think that there's colonic inertia. And if they all collect down in the rectum, it makes you think there's some outlet dysfunction. But all this starts happening once you come to GI clinic. Sometimes we'll do anorectal manometry to see if they have an increased rectal sensory threshold. Some kids, when they have rectal distension, they have paradoxical contraction of the external anal sphincter instead of relaxation. And you may pick that up on anorectal manometry. And if there's obviously failure of relaxation of the internal sphincter, which is an involuntary muscle, that makes you think about Hirschsprung's disease, okay? And often, or not so often, we will have to do a rectal biopsy in an infant, sometimes even in an older child, to make sure we're not dealing with Hirschsprung's disease. And there you won't see any ganglion cells. So this is a slide showing anorectal manometry. So there's a catheter placed in the anal canal. There's two sensors, one against the internal sphincter, which is involuntary, and one against the external sphincter, which is voluntary. And then we distend the rectum with a balloon. And up on the top, you can see normally when the rectum distends, the internal sphincter relaxes. Well, how do I do this? I don't know how to do this. If you look on the far right side in Hirschsprung's disease, when you distend the anal canal, you can see that the internal sphincter does not relax. And that makes you suspicious that there is Hirschsprung's disease and you will need a rectal biopsy, okay? So how do you make a diagnosis of functional constipation? If the history and physical exam are not consistent with organic disease, functional constipation can be diagnosed. And if you find that you're starting to treat functional constipation and you're not getting the results that you are looking for, then you need to start thinking about what are the organic causes of constipation that we need to rule out. So how do we manage a child with functional constipation? It's fivefold. First, we need to educate the family and the older child about the pathophysiology of constipation. We need to start with a clean colon and disimpact them, put them on a maintenance regimen so that they poop every day, retrain their bowel, and then always provide support for the family and the child. Sometimes I say support for the treating physician too. So education of the parent and child, we need to educate them as to how the bowel works, why we're intervening, why we need to be persistent, because it can take a while for constipation to improve, and always explain to them that they're not going to get dependent on the medicines. Some parents are always worried that the child will never poop unless we give them medication. And we have to explain to them that once we get them pooping every day and the rectum shrinks down to its normal size, you will not be dependent on medication. And then eliminate the frustration and demystification of constipation. And we found over the years that once you educate the family and the child, it always will improve their compliance with the treatment that we're recommending. So typically we'll start with the clean out phase to get the colon cleaned of all the poop that there is. You can use various drugs in various routes. Oral medications are preferred. We sometimes will do combination therapy with an osmotic laxative and a stimulant. Try and avoid using medications from below, like enemas or suppository, unless there's a big, huge fecaloma, a fecal impaction. Sometimes we'll have to bring them into the hospital to do a nasogastric polyethylene glycol treatment with an NG tube. That's if you failed outpatient clean out. And really, you'll have to resort to a surgical disimpaction to get that poop homa out from the rectum. So the choice of drugs is not as important as compliance with the medication. So the clean out that we will do as an outpatient, we'll use polyethylene glycol with clear liquids, usually for 2 days. We'll often add a stimulant, either bisacodyl or senna or magnesium. I have tried many moons ago to do a clean out with mineral oil. That was a disaster. The mom had to use all the towels in her closet because the kid was leaking oil all the time. So don't do that one anymore. So usually polyethylene glycol works well. You can add magnesium citrate as a stimulant to the polyethylene glycol. Rarely I have used lactulose, high-dose lactulose to clean out. And during this clean out phase, since we want to clean the colon out, we put the child on a clear liquid diet. So it's clear liquid diet with osmotic laxatives and plus minus a stimulant laxative too to get the colon cleaned out. If there is on rectal exam, you can feel a hard stool, you may want to just jumpstart by giving an enema to get that pupoma out. So hypertonic sodium phosphate, you can use a mineral oil enema. We have used milk and molasses enemas. They're very hypertonic. There was some case reports of death with kids getting milk and molasses enemas, but there was another study and they looked at it and it is pretty safe. Some people still use soap suds enema and will sometimes use a combination of saline, mineral oil, and glycerin. So it really doesn't matter what enema you use. It matters that what enema you give works. So to get that pupoma out from the bottom so you can clean out from the top. We will sometimes admit kids to the hospital to do nasogastric polyethylene glycol cleanouts. I'll usually reserve this for kids who have failed 2 outpatient cleanouts at home. So they come in and they get an NG tube and then we'll run this polyethylene glycol continuously. They may or may not need IV fluid. IV fluid is needed if they can't drink enough fluid over and above the polyethylene glycol that's infusing through their NG tube. They may need an enema to jumpstart this clean out. So it's important to do a rectal exam before you start this clean out to make sure that we don't have fecaloma there to get things started. So, NG go lightly after you failed 2 outpatient cleanouts. So once you have the child cleaned out, we need to put them on a good maintenance regimen so that we don't reaccumulate stool in there. If the kids are withholding, then we need to overcome this withholding. They have to realize that pooping is not painful and they can have a bowel movement without pain. And this includes a combination of meds and diet and a lot of cheering and positive reinforcement. And we need to continue this maintenance phase for at least 3 months, sometimes up to years. I usually say if the constipation has been going on for X amount of months, it's usually X divided by 2 is how long they're going to be on meds. And we don't just stop the meds one fine day. We usually start tapering down as we're working on their diet and their physical activity. So for maintenance, we'll use a combination of stool softeners or stimulants. And it's not so important as to what medicine you pick. It's more important that the child is able to take it without any song and dance, and there's no battle of the wills going on at home with the child taking their medication. I put in here, there's no such thing as a maximum dose. You can push till the child is having soft form stools daily. And we want to induce 1 to 2 soft bowel movements a day so that stool doesn't start reaccumulating in the colon. And like I said before, once you've found an adequate dose, it's important to continue the medications for a minimum of 3 months, sometimes even longer. And like I said before, we don't just stop the meds, we gradually wean as we're working on diet and positive reinforcement for the child to go in the potty and get used to sitting on the potty and having painless, soft form bowel movements every day. This is a slide that goes over the medications that we use for constipation. So there's a combination of osmotic medications, lactulose, sorbitol, magnesium hydroxide, mag citrate, polyethylene glycol. The doses are in there. We'll often use a lubricant, mineral oil. You have to worry about giving mineral oil to, never give it to an infant under the age of 1, because you can aspirate it, and never give it to a child who has a dysfunctional swallow. So a lot of our MRCP kids, I will never give them mineral oil. And then we'll often add a stimulant, either senna or bisacodyl, usually right after the clean out phase, just to make sure while we're retraining their bowel that they don't get backed up again. So you can use a stimulant initially after a clean out, but the goal is to come off the stimulant within a couple of weeks and just use the osmotic laxative as you're working on their diet. So maintenance meds, like I said, mineral oil, lactulose, milk of mag, barley malt extract, and polyethylene glycol are the medications that we use for constipation. So already said this, for the mineral oil, contraindicated in infants, anybody who's vomiting a lot, and anybody who has a dysfunctional swallow due to the risk of aspiration. Because if you aspirate mineral oil, you have to have an emergent bronchoscopy to lavage it out. So in older kids, some kids will just shot glass that mineral oil. It doesn't taste very good. It's tasteless, but it just kind of slides down your throat. You can mix it actually in yogurt, or put it with juice or with some ice and make it into a slushy. So it just lubricates so the child can't withhold. And sometimes in the beginning, I will tell the families, if we're using mineral oil, I actually want to see some of the mineral oil coming out in the poop to make sure that we know they're getting enough, and then we can start pulling back on the dose a little bit. We can use lactulose. It's an osmotic agent. It's non-absorbable carbohydrate. It may cause bloating because initially the lactulose will get fermented by some of the bacteria in the colon, and they may be gassy before the gassiness goes away. So lactulose comes in powders and a really sweet orange flavor liquid. We'll use milk of magnesia. It's osmotic and it's a little stimulant. It comes as liquids, gummies, watermelon flavored chewable tablets. There's a berry flavored gummy that's now available. And like I said, you can just keep upping the dose till you find the dose that's going to work for the child. Barley malt extract is an osmotic laxative, and you can mix that even with a baby bottle of milk to help them poop, but that may cause bloating too. Polyethylene glycol is a non-absorbable osmotic agent. It's safe even in infants down to the age of 16 months. We usually mix it with a clear beverage. It doesn't work as well when you mix it with milk. There was a study looking at comparing lactulose with polyethylene glycol, and the polyethylene glycol seemed to be more efficient with lesser side effects than the lactulose. Another study was done looking at polyethylene glycol and milk of magnesia. The efficacy was similar at 1 year follow-up, but about a third of the kids who were taking milk of magnesia did not like the taste of the medicine. We'll sometimes use senna. It's a stimulant to get things going right after the clean out. We usually don't like to keep them on it longer than a couple of months and try and wean it down gradually. And this senna comes in liquids, it comes in granules, it comes in a fruit roll up and chocolate squares in order to entice the kids to take them well, okay? There are other medications that we can use for kids older than 18, but they're not approved for kids under the age of 18. Lubiprostone is a chloride channel stimulator. There's linaclotide and procalopramide, which is a 5-HT4 receptor agonist. Sometimes we will use this in older kids, but it's not approved for younger kids. So X-Lax. And then we always have to look at their diet in kids with functional constipation, make sure they get enough fluid and fiber in their diet. There are recommendations as to how much fiber a child needs. It's over the age of 2. So it's age in years plus 5. It doesn't mean that I'm 60, I need 65 grams of fiber a day. Cap it off at 25 grams of fiber a day. We go over food choices with the children. We have a little handout. It goes over foods that have 1, 2, 3, 4 grams of fiber in them. And you can also buy commercially available fiber in the form of powders, tablets, granules, and cookies to get them to eat more fiber. Never forget about making sure they get enough water in their diet. We need to avoid excess milk and juice in their diet. Sometimes we'll see kids drinking a lot of milk, and what they do is when they're drinking a lot of milk, they just fill themselves up with milk and don't want to eat the foods that have enough fiber in them. So you all know how to calculate fluid requirements for a child, right? It's 100 mLs per kilo for the first 10, then 50, and for the next 10 kilos, and then 10 mLs per kilo for the next. I usually write this down for them at the clinic visit as to how much fluid we want them to drink. This is not something that's going to happen overnight, and we just have to cheer the kids on. And yes, you drank so many ounces of fluid every day at this visit, and the next visit our goal is going to be a little bit higher. Okay. And it's important for the family not to isolate the child and say, well, you need to eat so much fiber. Well, the parent's not eating all this. So the whole family needs to change their eating habits. And it's really important to avoid the battle of the wills. And the whole family needs to be on board to get the child to try and eat more fiber and fluid, and always have to lead by example, right? So the family has to change their eating patterns and what they have at the table at mealtime. So for retraining the bowel, we want to make sure that the child has regular toilet times. After we eat, the colon contracts. It's the gastrocolic reflex, so we want to make the most of that. So we want to make sure that the child sits on the potty after their meals. It can be a little bit frustrating for the parent and the child, so we always have positive reinforcement. Sit on the potty, there's no distractions. Make sure they have good foot support, because you want to make sure that they are able to use their muscles well, and give them an incentive for potty time, not pooping. We usually start incentive for potty time to begin with, get them sitting on the potty, and then add an incentive for sitting and pooping on the potty. Okay. So we usually have them have a calendar in the bathroom. Every time they sit on the potty, they get a star. And when they get so many stars, they get a prize. Make it small, make it achievable. I say when you get whatever, if the kid can count to number 20, at 20 stars, you go to the dollar store and you pick out a prize. I had one mom that redid the kid's room after she got so many stars. I said, well, I never told you to do that. I just said, keep it small and achievable so the kid is motivated. Never any negative consequences, even if they're soiling. It's very hard for the families to get on board with them with that, but with enough teaching and talking to, they soon realize that it's in everybody's best interest to focus on the positive reinforcement and never have any negative reinforcements. I'll often tell the kids, when you bring me a calendar and there's 15 stars on it, I will do a little jig in the office. I just have to kind of keep them motivated to keep on going to poop in the potty. So always have incentives for potty time. And this child, even though he's sitting on the potty, we need to not forget that they need to have adequate foot support so they can use all their muscles for defecation. Bedtime reading material, anything for positive reinforcement, okay? There's a lot of online resources. There's a video called The Poo in You on YouTube. There are apps now for potty training tips. The AAP has a handout for toileting in children, and the Squatty Potty also has some material for the families and the kids, or for resources for good pooping. Support is really important. We need to have frequent contact with the family and the child by phone or email and office visits. The the parents and us have to be persistent, because we can get through this. We just have to be at it and have our goals and try and meet them. We need to be optimistic. Us as medical providers need to be optimistic that yes, we can do this, we can do this. If we have a child that we're getting into issues with control or non-compliance, then we can call our friendly psychologist to help us with the positive reinforcement and non-compliance and control issues. And then what do you do about weaning medications? How long are you going to leave a child on an osmotic laxative, or any kind of laxative for that matter? So we usually taper the meds, never stop it, and gradually taper the meds every 3 to 6 months. Discontinuing the meds is too soon is the most common cause of relapse of constipation. So I will usually tell the families that if your child has been constipated for 2 years, you have that amount of time. So for at least a year after we've been cleaned out and pooping every day, that's how long we're going to be on some kind of medication. So usually we're seeing these kids in the office for a fair amount of time after they come to clinic till we can wean them off their medications, get them sitting on the potty and altering their diet so that we don't have a setback. Quite often we will have a setback. We may need to do a mini clean out at home. But once again, we always try and be optimistic and say, we had a setback, but that's fine. We'll continue and we'll get there. Okay. I just wanted to spend some time talking about interventions that we can do in kids who have chronic refractory constipation. There is a bowel management tube. It's like a G tube, but you put it in the insert it rectally. There's a balloon at the end, and you basically give an enema while they're sitting on the potty, and they will poop out the tube with the poop, and it only cleans out the distal sigmoid colon. Rarely we will have to put in a ACE tube, which is an antegrade continence enema. You put in a low profile tube into the cecum to do a retrograde flush from the cecum downwards. Those are in kids that it's not functional constipation usually. They usually have a motility issue. There's also a transanal irrigation system where you insert a catheter in the rectum while they're sitting on the potty. It's a closed system, and you connect it to the tap in the sink, and it kind of does an enema while they're sitting on the potty, but you're not touching or doing anything, and you insert the catheter rectally, and it automatically flushes it with a pedal on the floor to evacuate the rectum and distal sigmoid colon. There is also a sacral nerve stimulator that some centers are using now. It's a appliance you attach to their ankle, and the stimulation goes up to the pudendal nerve, and it helps them to have a bowel movement on the potty too. So these are things that you do when you have refractory constipation, but by that time they're off to a tertiary care center to have their interventions done. So what's the prognosis of functional constipation? The success rate is anywhere from 50 to 100%. With close monitoring, the success rate is about 60%. Poor predictors for constipation if you have soiling, if there's a early onset of constipation, there's a family history, and if there's an obese male with behavioral issues. There was one study done not too long ago looking at the prognosis of functional constipation in children. All these were referred to pediatric GI. And after 6 to 12 months, 50% had recovered and were without laxative therapy. 10% were well while taking laxatives, and 40% were still symptomatic despite the use of laxatives. However, at 5 years, 50% had recovered and were not taking any laxative. After 10 years, that's a long time, 80% were recovered and no longer taking any laxatives. And they also found that a delay in the initial medical management for greater than 3 months from symptom onset correlated with longer duration of symptoms. So once we find a child who's constipated, we should start intervening quickly. Okay, so as a pediatrician, I have to put in a plug for prevention. It's really important to educate the child and the family of a well-balanced diet with adequate fluid and fiber in it. It's important that well child visits, we ask about the stooling pattern. It's also important that we avoid overtreatment of transitory episodes of constipation, because then that can sometimes start that withholding pattern. And at the same time, we need to avoid ignoring painful rectal conditions. Sometimes it's hard to find that balance, but it's really important that we ask at well child visits about stooling patterns and behavior. Okay. So we're back to our little boy, our 4-year-old that came to our clinic for constipation since he was 2 years old. Mom had tried giving him prune juice, carob syrup, and with not much help. Since he's been toilet trained, his constipation got worse. He stools every 3 days. It's painful. He refuses to sit on the potty now to poop, but he pees just fine. He's in good health, growing well. He drinks 3 to 4 cups of milk a day, likes to eat junk food and maybe some vegetables. On exam, he had palpable stool in his abdomen. He had a normal anal wink, no sacral dimple, normal rectal tone. And when you did that digital exam, there was a large hard stool in the vault. So what are we going to do here? Anybody? What's our differential diagnosis?
Functional constipation.
Functional constipation. Would you like to do any testing on him?
I would not.
Okay, and which is fine. We're going, and how are we going to treat him? So we're going to remember we felt stool on his belly exam, and we felt stool in the rectal vault. So before we do anything, we need to start with a clean colon. So we need to do a clean out, and in him, I would do a home clean out, probably just using some magnesium citrate and Miralax. May or may not start with an enema because he had a large stool in the vault, and then put him on a good maintenance regimen with whatever laxative he would take. We could use a polyethylene glycol, we could use lactulose, we could use mineral oil, may or maybe with or without some stimulant, and then start him on a retraining for his colon with potty times, make sure he has good foot support and poops every day with whatever we're giving him. What about his diet? So age and years +5 for fiber, and make sure he gets enough fluid in his diet. Looks like he was drinking too much milk, so cut that dairy intake so he starts drinking more water, and get all that, start working on that junk food. It's easy for us to say, but it's a lifestyle change, so we always have to start with a goal in mind and gradually get there. And potty times, make sure his feet touch the ground when he's sitting on the potty. Cheer him on for sitting on the potty. Cheer him even more if he sits on the potty and poops on the potty. Okay. So moving on, looking at time here. Oops. So I'm going to go quick. So we have a 3-month-old girl that came to our clinic for constipation since she was born. She's having a soft to hard stool every 6 to 7 days after a glycerin suppository. Mom can't remember when she passed meconium at birth because she was in the NICU for RDS for 4 days. She was breastfed initially, but now on a standard infant formula. She's eating well, no vomiting. She's gaining and growing well. Otherwise, she's healthy. She has a normal newborn screen. Physical exam revealed a soft abdomen. She had a normal anal wink. There was no sacral dimple on her lower back. On digital exam, she had a normal tone. There was soft stool in the vault. And after the rectal exam, she had a stool. So what is our differential diagnosis in this 3-month-old with who's only stooling after she gets a glycerin suppository? So what is our differential diagnosis here? Oops.
Possibly Hirschsprung's.
What else? We're thinking Hirschsprung's because she's pooping after we relieved the obstruction with a suppository, and you did a digital exam And when you relieve the obstruction, she had a stool. What else should we be thinking of in this 3-month-old baby with constipation? Hypothyroidism is in the differential for a baby, but her newborn screen was normal. What else should we be thinking of? Sometimes milk protein allergy can masquerade like this too. So we need to be thinking about that too for milk protein allergy. But this kid, we have to make sure the most important thing we need to make sure in an infant is we're not missing Hirschsprung's disease. So what is Hirschsprung's disease? It's a congenital absence of the ganglion cells where the affected segment remains in a state of tonic contraction, producing a functional obstruction. It just won't relax. Happens 1 in 5,000. It's more common in males. There's a gene identified for Hirschsprung's disease, so it's hereditary in 20%. It's also associated with trisomy 21. And this aganglionic segment starts from the distal rectum and works its way up in varying segments of the colon, sometimes even into the small bowel. Okay, so there's tonic contraction in that area. So often these babies will have a delay in the passage of meconium. In the neonatal period, they may have obstructive symptoms with bilious vomiting. They could get enterocolitis when they're infants. And when they're older, they have infrequent stools. And typically the stools are narrow and ribbon-like. And often these kids will have failure to thrive too. Okay. So the rectal exam in Hirschsprung's disease is typical. The small caliber anal canal. That's why they have ribbon-like stools. When you put your finger in the rectum, it's empty. And when you take your finger out, there's a gush of stool. That stool and gas comes flying out. I've had it on my face, on my hair, on my clothes, on the mother's hair. So if you have that gush of stool, you just need to start thinking Hirschsprung's disease. So remember, this area is tonically contracted. It cannot relax. So you do not see those large stools and soiling because there's a functional obstruction. The functional constipator will have large hard stools with soiling. Okay. To make a diagnosis of Hirschsprung's disease, you need a rectal biopsy. It's a full thickness rectal biopsy. You have to go to the submucosa. So me doing a colonoscopy and get a sigmoidoscopy, getting a superficial biopsy is not going to do it. We need to go down to the submucosa. So you have to do a full thickness rectal biopsy, or you can do a suction rectal biopsy so you get down to the submucosa. And you will not find any ganglion cells on the biopsy, and you will see these thickened nerves. They're looking for those ganglion cells. You can also do some stains to rule out Hirschsprung's. You'll see the negative stain for calretin, and it stains those ganglion cells, and it'll be negative if you have Hirschsprung's. You won't find any ganglion cells. You can screen for Hirschsprung's with a barium enema. You do an unprepped barium enema, and you'll see a transition zone where the aganglionic segment, and this is the normal segment. So you can see this is the transition zone here. And also these kids, remember, they have a functional, they have a obstruction. So they will not evacuate that barium right away, right after the barium enema. A normal kid, like a functional constipated, if you put the barium in there, they'll poop it out right away. So these kids will have a delayed evacuation of the barium. So if they don't pass the barium that day, the radiologist will bring them back in 24 hours to see if they passed all that barium or not. So if there's delayed evacuation of barium also, you need to start being suspicious that this could be Hirschsprung's disease. Sometimes we will do anorectal manometry as a screen for Hirschsprung's disease. So there's a catheter in the child's rectum. The tip of it has a balloon on it. And normally when there is rectal distension or that balloon is inflated, you can see here that the internal anal sphincter relaxes. But in Hirschsprung's disease, when you have rectal distension, there's no relaxation of the internal sphincter. So you can screen with anorectal manometry and a barium enema, but the diagnosis is based on a biopsy. So we need to suspect Hirschsprung's disease. If there's a delayed passage of meconium, there's early onset of constipation, there's a history of ribbon-like stools or enterocolitis in infancy. In a child who has chronic refractory constipation, you're doing whatever you can to treat this constipation, not getting better, you need to start thinking, could it be Hirschsprung's disease? Or sometimes a very short segment of Hirschsprung's disease will masquerade as a functional constipator. And usually these kids do not withhold, there's no withholding, so they don't have this duty dancing. And when you do the rectal exam, I talked to you already, there's a empty rectum and a gushous stool. So this slide just goes over the differences between functional constipation and Hirschsprung's disease. Usually the Hirschsprung's kids start out right from infancy. They had to have delayed passage of meconium. They say it's rare in Hirschsprung's, but it can still happen. They have usually don't have rectal bleeding and abdominal pain. They don't get fissures. The stool caliber is small like a ribbon. The functional constipators will have a large hard stool that plugs the toilet. Hirschsprung's could have failure to thrive. The functionals usually don't. There's usually no behavior or dietary family issues with the Hirschsprung's that can be seen with the functional constipators. Hirschsprung's rarely soil. The functional constipators will soil. And we talked about the rectal exam in Hirschsprung's and a functional constipator. And then the anal fissures do not happen in the Hirschsprung's because they don't have big hard stools, but it's common in a functional constipator. Okay. So moving on, oh, I'm late, but I'm gonna do it. There's an 8-year-old girl comes to your clinic for constipation for the last 3 years. Her stools are large, hard, every 3 days in spite of polyethylene glycol. She passed meconium at birth, so we're not thinking Hirschsprung's. Potty training was uneventful. She's eating well, no vomiting, but she feels bloated often. Exam was, she had a soft belly. Perineal exam was normal. Digital, she had a large heart wall filled with putty-like stool. On reviewing her growth chart, her height started to cross percentiles at 6 years of age. Review of labs from a pediatrician's office revealed a microcytic anemia. So what do we think she has? So she did not have any delayed passage. She feels bloated. Her exam, she had some stool palpable, but her growth is starting to falter and she has a microcytic anemia. So what should we be thinking? To cut a long story short, we need to start thinking about celiac disease. So briefly, celiac disease is an immune-mediated enteropathy caused by permanent sensitivity to gluten, and it occurs in genetically susceptible individuals. They have to have either DQ2 or DQ8 positive HLA, okay? Typically, we think about celiac kids who have diarrhea, but no, constipation can happen too. And the theory behind that is maybe the gluten acts as a inhibitor to the motility for in the colon, okay? So celiac disease can present with constipation. They can also have anorexia, abdominal distension, failure to thrive, and bellyache, okay? So sometimes they will have non-GI manifestations too, like dermatitis herpetiformis, dental enamel hypoplasia, short stature, delayed puberty, iron deficiency anemia, arthritis, elevated liver functions, mouth sores, and they can also rarely have some neurological symptoms like migraine and peripheral neuropathy, okay? I'm going to quickly go. This is dermatitis herpetiformis. It almost looks like chickenpox. It's blistering and then it's itchy. This is the only time when you don't need a gut biopsy to make the diagnosis. You can biopsy these lesions and make the diagnosis. Mouth sores can happen too. This is dental enamel hypoplasia, osteoporosis, short stature. About 10% of kids and teens with short stature will have celiac disease. Our friendly endocrinologists always screen the kids for celiac disease. Iron deficiency anemia, resistant to oral iron can happen too because they can't absorb it. And as a gastroenterologist, we always screen kids with elevated liver enzymes for celiac disease too. So you have to have the genes to have celiac disease. 90% will have DQ2, 20% will have DQ8 positive, but you have to remember the DQ2 can also be found in normal individuals. So if you're going to do gene testing, it only helps you if it's negative. It really doesn't help you if it's positive. To make a diagnosis of celiac disease, North American Society for Pediatric GI recommends that you have to have a biopsy to prove celiac disease. You can screen with serology and it'll support the diagnosis, but you cannot make a diagnosis based on serology. You have to have a small bowel biopsy. The most common test that we do now is a tissue transglutaminase, IgA. It's the most sensitive and most specific. We don't do the AGAs, which is anti-gliadins anymore, because they're not that sensitive and not that specific. We will do a deaminated gliadin peptide in younger kids under the age of 2 because the TTG is not as sensitive under the age of 2. So if you're thinking celiac disease, get a TTG IgA. About 3 to 5% of kids with celiac disease are IgA deficient. So whenever you order a TTG IgA, you have to order a total IgA level, okay? So all the testing that we do is based on IgA. So if a child is IgA deficient, then we can do the TTG IgG, okay? So all kids, if you're screening for celiac disease, you will order a total IgA. If they're 2 years or younger, you will do the TTG IgA and a deaminated gliadin IgA. Over the age of 2, you don't need to do the deaminated gliadin peptide. You only do a TTG IgA. There's one caveat: diabetics can have a false positive TTG IgA, so we will always do an endomysial antibody in those, depending on the TTG IgA. In diabetics, it's considered positive only if it's more than 3 times normal, the TTG IgA, not in other kids. Other kids, even if it's 1 point up above the normal, it's abnormal. Endoscopy, so it could look normal to the eye. This is the normal folds in the small bowel. You may see scalloping or you may see this nodularity, but it could look normal too to the eye. So we have to take a biopsy no matter what the small bowel looks like at endoscopy. And we have criteria. This is a normal villi. Initially, you'll get some increased epithelial lymphocytes on the surface of the villus. Then you'll get crypt hyperplasia, and then you start getting blunting of the villus. This is called the Marsh criteria for celiac disease. Treatment is a gluten-free diet for life. Avoid wheat, rye, barley, and oats. These days with the internet and apps, you can figure out which food, which brand has or does not have gluten in it. So this girl that we had a positive TTG IgA. Her biopsies showed Marsh 3 celiac disease, and she has to be on a gluten-free diet for life. Take-home messages: pediatric constipation and encopresis are common and curable. More than 95% is due to functional constipation, but we have to be aware of and rule out organic causes of constipation. What the mind does not know, the eyes will not see. In functional constipation, we have to be persistent. We too have to be persistent and have good follow-up and never give up, okay? We'll cure it. These are my references. If you have any questions, happy to answer any. And that is my happy place. That's the view from my bed every morning.
Beautiful.
Sorry.
Dr. Malkani, there was just one question in the chat. It's the incidence of anterior displaced anus and the diagnosis and treatment for that.
I don't know that there's any paper looking at the incidence of anteriorly displaced anus. There is criteria, and I had a slide, if I can find it, on how to diagnose it. But you know what? When you've looked at enough perianal areas, just by looking, you know it's there. And the treatment is just to keep the stool soft. I'm trying to find my slides because I had a backup slide. No, I lost it. Anyway, the treatment is just to keep the stool soft so that the stool doesn't have to make that, so that the stool can make that turn easily as it's coming out. In the 30 years of practice, I have never ever had to refer a kid for an anteriorly displaced anus for surgical correction. So just keep the stool soft and reassure the parent that when this child grows up, she'll be able to have kids fine. I'm looking for that slide. How do I get to my backup slides? Where are my slides?
I mean, they're in the PowerPoint.
Where's the PowerPoint? Oh, there's a PowerPoint. How did it go away?
I did that. I'm sorry.
Oh.
I can share them from here if you'd like.
I have to find the slide. I know I had it as a backup slide. Here we go. Is it showing?
No, I stopped your share. You're gonna have to reshare.
How do I do that? Share?
Yep. If your PowerPoint is open, the green share screen button at the bottom of your Zoom window.
Go back to Zoom.
Sorry about that.
There we go. Okay. There's a measurement how to do it in a boy and in a girl. Okay, but once you've looked at enough, you can tell it's anteriorly displaced. Let me get out of this. Anything else?
Nope, that was the only question that was in the
Okay.
chat. Thank you.
Thank you, Dr. Malkani.
Okay, thank you. Bye.
Thank you.
Get out of here. X out.
Now you unshare your screen.